Hello and welcome to Letters to My Daughters. I am so excited to get into the material that we have, the conversation that we have scheduled for Module 3. Before we do any of that, let's take some time to ground ourselves and to center ourselves. As you entered into that digital space, this digital space, you should have been prompted to place your prayer requests in the chat. I encourage you to do so also at this time, or simply introduce yourselves and let us know who you are the daughter, the son, the child of, what lineage you are bringing into this space, and where you are watching from. As we introduce ourselves and as we gather to prepare ourselves for this evening, for this time of conversation, let us first take a moment to pray. Gracious and eternal God, we give you thanks and praise for this time, this moment, this day that you have made. God, we thank you that you have been with us throughout the course of this day. And our prayer is that your spirit might continue on into this virtual space. God, I pray over everyone who has gathered here. I pray that you might open their minds and their hearts. God, I pray that you would have a word for them, a word, a mission, a task, a charge, that we might begin to expand our capacity for ministry, that we might begin to incorporate elements of the social conditions of women, girls, and femmes into how we show up as the church. God, I ask that you would be with us as we seek to do better, as we seek to do ministry anew, as we seek to be your hands and your feet in the edification of this, your beloved community. And so, oh God, our prayer is that you are with us throughout this time of discussion and sharing. And we will be sure to give your name all of the glory and the honor and the praise that is due. In Jesus' name we do pray. And together the people of God said amen. You all, we have made it to Module 3 of Letters to My Daughters. In this module, we are talking about the topic of the social and spiritual determinants of health. Now, the social determinants of health may be a familiar concept to you, and that is what we will discuss in tonight's virtual session. But the spiritual determinants of health, specifically as it relates to Black maternal health, is something that I've been musing on and toiling with. And we will get deeper into that in the podcast, the weekly devotional podcast, just something for us to muse on in terms of how we might be able to see markers for preparedness within our faith communities and our churches to be able to respond to these social conditions that directly impact women, girls, and femmes. But tonight, during this conversation, I am honored. I'm honored to be able to join in conversation with my Spelman sister, Dr. Fleda Mask Jackson. I'm so excited for that conversation. Before we get into it, let me share a few things about her. Dr. Jackson is a scholar, educator, and activist. She is the author of numerous peer-reviewed publications and presentations on the topic of racial and gendered stress and its impact on maternal and infant outcomes for African American women. Dr. Jackson has appeared in a number of documentaries, including When the Bough Breaks, Unnatural Causes, Is Inequality Making Us Sick? She has been cited in articles for ProPublica, for NPR, for Essence, and Ebony, among others. And Dr. Jackson has also served as a consultant and advisor for institutions and organizations, including the Center for Excellence in Women's Health at Harvard Medical School, the Ford Foundation, the Joint Center for Political and Economic Studies, and the Children Defense Fund's Southern Regional Office. She's also served as a member of the advisory subcommittee on health disparities for the director of Center for Disease Control and Prevention, and was approved by the Obama White House to be a member of the Secretary's Advisory Committee on Infant Mortality. I hope that you all are able to glean as much as I did from this conversation with Dr. Fleda Mask Jackson. Check it out. Well, Dr. Jackson, thank you so much for just taking the time out to join in conversation. When you said yes, I was over the moon excited. And so for the people who are gathered, can you begin? I'd like for us to start by you introducing yourself. For the context of Letters to My Daughters, I'm a womanist theologian and practitioner, and so I like to open up by naming the lineage that we bring, women who have come before us. And so can you introduce yourself by telling us who you are, and specifically telling us who you are the daughter, the granddaughter, the great-granddaughter of, if you will.
Okay, so my name is Fleda Mask Jackson, and I am the daughter of Fleda Staten Mask, who was the daughter of Laura Staten. And I can't go back any further than that.
Okay.
What I can tell you about those Fledas and Laura, and also I'm the daughter, let me say something, I'm the sister of Maydell Boyer, and also the daughter of Verlene Ames, and that's because I have two mothers, and so I come from all of them. And I like, you're asking for this introduction because it reminds us who we really are, what our roots, and hopefully what our branches will become. And so Laura Staten was a midwife and herb doctor in North Carolina, who was a Christian woman, but who was known to have a fierce temper. And so, she would go off and then ask God for forgiveness, I suppose. Her daughter, Fleda, Fleda Staten Mask, was a humble woman who had done a number of things, but certainly fiercely believed in the education of her daughters, and which was myself and my sister Maydell, who was much older than myself. And so it was that while she didn't finish, she didn't go past elementary school, actually, in terms of her education. She made sure that her daughters went to private boarding school with myself and my sister, and that we could make it in a way in the world. I think about her when you say what we got from these individuals. She was a quiet woman who taught me the art of observation, which is key, which is critical, which is central to the work that I do. So that you begin, because she was an avid gardener and a naturalist who watched animals, the tiniest ones to larger ones. She gave me those skills, and those skills are really core to me as a researcher for what I do in terms of looking at Black women's health. So I come from Fleda, for whom I was named. I come from Verlene, who gave me birth, but Fleda gave me the full life. I come from Laura Staten, so that's my lineage.
We give thanks for Fleda and Laura and the lineage of Fledas. I'm grateful that you made that connection, right, of the lives that they lived and how they have contributed to how you show up as a researcher. And I'd like us to lay the context here. So we're talking about, specifically for this iteration, this module of Letters to My Daughters, how Black maternal health is being discussed within the academy, within this the this notion of looking at the social determinants, right, of Black maternal health, and how they
Uh-huh.
can be applied to the work and how we show up within religious communities. So, can you
Uh-huh.
talk a little bit about your research? And if you would, give us an overview of some of the work and some of the questions that you've been asking.
Okay, so I'm going to give a little background about how I got here.
Okay.
I am not a physician.
Mhm.
I'm not a nurse. I'm not someone who is a provider in the whole enterprise that deals with maternal and infant health. I am someone who was trained in child development and family studies to look at the life course of what happens for children, for mothers, for fathers, and what takes place in terms of those relationships within families. But as that is my has was my area of my area of interest
Mm.
and expertise that was I was given in graduate school, I also became a methodologist, someone who understood the integration of qualitative research, where we listen to the voices, where we hear what people say, and quantitative, where we measure. So it was in the late um, 1980s, I was approached to be part of a grant proposal that was going to look at Black women's health. Um, and so I took the charge, and as a consequence of that, but before that, while I was at Spelman College,
Mhm.
I received a request as an alumni to fill out this application, or fill out this survey rather, that was really focused on Black infant deaths. Well, I didn't know that Black babies were 2 to 3 times more likely to die before their first birthday then. Seemed like we were doing okay. Yes, I knew of incidents as someone who had miscarried myself. I knew that these things happened, but not to the extent that the data was telling us. I got angry about that survey and refused to fill it out. Came from the alumni office, tore it up.
Mhm.
Second request came, tore it up. I say that God has a sense of humor because fast forward to what I just told you about how I got involved in this research. Here I was approached to get into this very thing. And I said, okay, I'll be involved. Well, little did I know that 20 years later, I would still be in this thing that I tore up the survey for. But again, God has a sense of humor. Now, what am I doing? Well, one of the things that happened after, there were individuals who did fill out the survey, not me, as I said,
Mhm.
but that data and other data similar to it, which was the survey was administered, or the appeal was made to college educated African American women like myself. In Atlanta at the time, it was Spelman and Clark, Atlanta University, of which was then I think still Clark, but those alumni of those schools in the AV Center, Black women alumni. And the survey was also administered to women at Agnes Scott, which at that time was predominantly white.
Okay.
So it was that kind of comparing those two populations, Black, white, college educated, expectation that income, that individuals had knowledge about their bodies, about what they need to do in pregnancy, that they had access to health care. All of those things were presumed to be equal. Okay, so all things being equal, you expect the birth outcomes to be similar.
Right.
Huh. The data from that study, the data from other studies which enrolled well educated African American women said, no, no, no. That even with a college degree, African American women had worse birth outcomes compared to their counterparts. Worse still was the research that showed that African American women with college degrees had worse outcomes than white women who had high school or less, unemployed, and no insurance. Wow. This really contradicted everything that we thought would be. And it started a pathway to say, well, what is it? What is it? So I entered the stage to answer the question of what could be the possible explanation for this? Why did it not matter that us with our Spelman degrees, that all that we knew, all that we understood about being healthy or about taking care of ourselves, taking care of babies, certainly getting the best possible health care during pregnancy was not protected for us in the way that we thought it would be. And so I was called along with people all over the country to uncover what was the explanation. How did we do it? Well, we talked to the women. That was the first principle of research, this womanist research that embodies and understands not we call the lived experience. I'm going to say the lived expertise. That honor the lived expertise. Okay, the lived expertise of Black women, and so presenting to them what the data showed, not only about pregnancy outcomes, but about hypertension and stroke and cardiovascular disease and premature deaths and cancer outcomes, all of that, that we unfortunately were the head of the class. Top. On the bar, we were the top. Not where we wanted to be in this case. We wanted to be lower on the bar. And so my journey began listening to the voices of African American women from all walks of life. Certainly started with well-educated African American women and asking them, first of all, what did they think was the explanation? And people gave the usual diet and exercise and lack of diet, poor diet, exercise, but inevitably they said stress. 2-1, they said stress. So that really laid out the roadmap for finding explanation. What was stress? What did they see as stress? What was the source of that stress? But also understanding that stress is a dynamic process. It's not just what you're exposed to that interrupts what it is that your goal is. It also includes those resources, those personal resources, those instrumental resources, whatever resource to mitigate those stress. And it's when those things come together, when there's an imbalance between that, and that imbalance, if you think of it like a seesaw, stays up and never comes back together, it creates not only mental distress, but it also creates physiological responses. So my work over these many years has been to really both document the particular stressors that Black women from all stripes, both in pregnancy and outside of pregnancy, and looking at that stress both in terms of the exposures as well as the things that we employ to mitigate. So that has been my work. And in that work, some key findings have been that stress comes from racism, not surprising. And when that racism is targeted toward the youngest of us, our children, it is particularly stressful. The stress comes from the burden of gendered roles, expectations, discrimination, which meaning that things happen because of our gender that is unfair, unjust, discriminatory. That stress comes from the burden of the expectations of those roles. So having to care for everyone, but not caring for ourselves. The stress comes from the workplace, where there's discrimination because of race, because of gender, because of the intersection of race and gender. The stress comes from personal history of abuse, whether it is physical, mental, or sexual abuse. And so that toxic soup of all those things come together that create stress for us. And that's what women talk to us about. They talked about how many people they had to care for in their families. They talked about seeing others advance in the workplace where they knew they were equally. They talked about being unwelcome. As one woman said, she said, I walked in and they looked at me as if, why was I here? What was my role? What was I, as if I did not belong there in the first place? Or talking about their children, where women talked about going to the store with their young boys and watching the store manager follow their young children. Those kind of things they talked about and just listen to the authoritative knowledge that they had about stress. But on the other hand, we also asked, what do you do when confronted with these stressors?
Mm.
And there were areas that provided social support, areas that provide a reassurance for who they were, who they are. And there were responses that really dealt with faith, spirituality, and religiosity. And so we saw those as the ways that they employed strategies, if you will, to attenuate those stressors. And again, on the stress mediator side, it was social support, girlfriending, as we call. Who are those people you could talk to about anything? And people talked about those people they could talk to about anything. It was their religiosity and spirituality. So it was both religiosity in terms of a place, a community where they could go to, and spirituality in terms of the practices that they employed, whether that was prayer or meditation or whatever it is that they did to mitigate what was going on. It was history and culture. So individuals recognized it was sung by Black women that they turned to in terms of an example of being strong, of being resilient, of doing all the things. And then there was some self-care things, but we didn't focus so much on that. The last thing that we asked women is, how do you feel? Because when we talk about stress, we talk about it both as an exposure, but we also talk about a response. And that response can come in the way your emotions are. So how do you feel? Feeling alone. I'm so stressed out, I'm by myself. Feeling overwhelmed. Unable to express your anger. Okay. And not having enough time to do anything. So those were some of the things that they said. So all of this in my work has come together to create what we call a contextualized stress measure. Because see, it comes from the context of their lives. It's very specific to African American women. And people ask me this all the time. The concept of contextualized stress is certainly applicable across any population. But contextualized stress for Black women is those specific things, those lived experiences, both of stressors and stress mediators, and the emotions that are historical, that are contemporary, that are life course. And so my work started looking at women, talking to women from all walks of life from 17 to 77. So it's life course, but kind of narrowing down eventually to pregnant women. So what are some of the key findings? That this contextualized stress at the higher levels, when you have higher indicators of stress with lower mediators, is a prediction of depression. That's the outcome, mental health depression. That's related to people not being able to sleep. Okay? That's related to them having malaise and all the things that come with being stressed and continuously stressed with no real release from it because it is habitual. It's everywhere. It happens. So one of the things that we are now looking at is how do those stress attenuate the stressors. And religiosity and spirituality is right in there as something for those women who are in a certain range. Now, there are those women who are high, what we call high contextualized stress. They really don't have many of those things at all. But for women who are at the moderate and low level, those are the things that seem to help them mitigate the effects of stress. Now, one of the things we did find out is that in this role of caring for children, when we looked at women who were expectant, pregnant individuals, we found that if for one of our statements, there's one of the statements that we have on this tool, which is called the Jackson Hole Phillips contextualized stress measure. It says, my children are more likely to have negative encounters with the police. That's kind of a paraphrase. That's not exactly the word. And what we found for individuals who were pregnant, as well as individuals who had children less than 5 years old, and especially if they had male children, and they agreed with that statement, that was a strong predictor of them having depression. So basically what that says, that even in the womb, the particular concerns, worries about children, about Black children, are affecting the mother. And if the mother is depressed, the physiological indication of depression also affecting her child. So that has been the nature of my work on the research side. I've had the good fortune to be able to work with different groups. I'm one of the founding members of Black Mamas Matter Alliance, and I was just very just thrilled to be part of that beginnings, which has had its footprint. And as your previous guest talked about the Mama Bus Act, and we've been there and just in lots of places. I've had the great fortune to work with Healthy Start, which I'm going to give kudos to one of our alumni, Dr. Audrey Manley, who was part of that. Its genesis in the early 1990s, and they're still going strong. I have had the good fortune of being, Healthy Start, Black Mamas Matter, and the March of Dimes in terms of some of their renovation of who they are and the whole emphasis on equity. But this equity, my work, as women talk about what it's like when they have to go outside their communities to get things. That's a social determinant. That means that a community is under-resourced. So if it's under-resourced and you have to take your children to other places outside the community, that's added burden. And so I've had the opportunity to be with these different entities to see how we can be central to these policies around housing, around food insecurity, around transportation, around schooling, because all of these things are part of the stress exposure for expected individuals, for expected mothers, as they carry a child and await the birth of the child, but also have to, at the beginning, think about how they will care for the child and what environment they're in. So that's been the nature of my work, which has had some influence on the policy side. I've certainly listened and learned in terms of providers and what it is they are able to do, and on the assessment and screening side, which is mainly my focus in terms of what I mainly write and publish about in terms of what contextualized stress and using measures that are a reflection of who we are.
Thank you. Named so much that I want to ask quick follow-up questions on. So for those of us, so for the clergy and the lay who are listening, right, congregants who are listening, I want to make sure that we brings out this element of social determinants of health. Can you explain,
Mhm,
and you right, everything that you mentioned, right, and have talked about, right,
mhm,
is within that category.
mhm,
But can you explain
mhm,
for them, right, how we are defining what social determinants of health
mhm.
are?
So the social determinants of health really looks at those things which are outside of the medical sphere, but are risk as well as protectors for health. So we understand that 80% of the causal or contributing factors to health are not within the medical domain. We've already recognized that. So that yes, individuals have heart disease and they have cancer and they have diabetes and they have any numbers of those things. And so by the time they entered the medical system, we are dealing with medical treatment and hopefully cure, but medical treatment. But how do we get there in the first place? And so the social determinants really makes us look at those things that both are risk for the disease as well as risk for the worsening of disease and risk for premature death. And so what does that mean? So uh, I was reading the other day about Medicaid expansion in Mississippi, and it's a particular county.
Mhm.
And this woman has been very sick, and there was a program of, I guess, visiting nurses, nurse practitioner, home visitation. And when they came to her home, they saw it was in such disrepair. Things that created mold, questionable water, questionable, lots of things that were questionable. And so the solution for this particular program is not new. I had a neighbor who did this for a private insurer, was that if we repair the environment that she lives in, we will improve her health. And so a portion, about $5,000, I think I just read this in the New York Times the other day, about $5,000 of her coverage was used to repair the house, okay? To get the house, get her living environment. And supposedly her health improved. Well, why would her health improve? If she's been so stressed out about the conditions under which she lives, that stress creates a physiological response.
Mhm.
It's not just in your head. The cortisol levels that remain so high and all other kinds of immune functions that are suppressed, all of those things contribute to poor health outcomes. So when we talk about the social determinants, we are talking about anything, all of those things that are outside of medical care. Okay, now there are some things that are social determinants that are within medical care, and that's racism.
Mm.
Okay, because racism is a prevailing ill that prevents people from getting what they need, when they need it, and how they need it, is a social determinant that resides in medical care too. That's really been a strong focus on the whole maternal mortality issue, and that is that everybody is not being heard, and heard in a way that is most responsive to the needs that they have and the medical situations that need to be addressed.
Yes.
So, social determinants is something that the World Health Organization advanced, and that we begin to say, okay, if we have these other things So, so you give somebody a medication, you give them a prescription. Okay, so there could be a number of social determinants that at play there. Is there a pharmacist in her area where she lives nearby? If not, is the transportation adequate to get her there? Are there issues about water in her house so she could take the medicine in the first place? Does it cost too much? Is the pharmacy open at other hours so that she could get it? Because when she left you, she had to get home. Is it too costly? Is it too costly? I can prescribe Eliquis for you, but at $140 some dollars of prescription, what you gonna do with
Nothing.
that? Okay. Okay, so those when we talk about social determinants, so I've just mentioned transportation, uh, income and employment, uh, accessibility to those resources. Those kind of are representative of what we mean by the social determinants of health. And some of that can only be addressed through policy. So the policy now that's put forth so that people who are diabetics do not have to pay those high prices for insulin, okay? Because the insulin was prescribed, and if we look at this in the maternal mortality space, gestational diabetes is a risk factor for diabetes later. Okay, so how do we make certain that over the life course and in the time when a second pregnancy is coming forth, that those things are placed? So for your audience listening, social determinants really represents those social, cultural, economic, structural factors, which are not necessarily within the immediate realm of, of, of direct medical care, but certainly begin to affect both the health outcome and the services that individuals receive.
I love that you mentioned legislatively, like what has happened, the importance of advocating for legislative components. So we are preparing and have been advocating, right, for the Black Maternal Health Omnibus Act throughout this current legislative session. And then recently, the General Board of Church and Society, we endorsed the Care for Moms Act that has come out of Representative Robin Kelly's office that does similar things and promotes the structures that you're talking about that are needed for promoting better maternal health outcomes. And so I say that because I want to stress that for people who are listening, right, advocating for these legislative measures to pass is extremely important. And
Yes, it is.
also, I believe that part of our mission is to draw this thread from how we show up within our element of public witness to sort of like how we show up in the pews, right? And so I appreciate what you said about the connection between mitigating stress and faith and spirituality. And I want to shift because I want to know how this might implicate the church or just faith communities in general, right? That we have this task before us to advocate for legislative measures to support structures that would support maternal health. And also in drawing the thread, we are the beloved community, right? That is the crown that has been placed upon our heads, you know? And so
Yes, yes.
what does it look like for churches to to join in this work, and I firmly believe that this is something that, like, we don't have to recreate the wheel with this. I think it's a measure of expanding our capacity for uh, for specialized care, right? These issues that are affecting women, girls, and femmes.
Mhm.
But I want to ask you, how might the church show up in this regard? And how might the church become involved in responding to this issue of maternal health, this issue of reducing stress factors?
So I want to, as you and I talked about this in preparation for today, I do have some thoughts about this and observations.
Okay.
Observations. So as Christian, we 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 point to the genesis of our faith around the birth of a baby.
Hmm. Okay. Let's talk. Okay.
Birth-
Mary. Birth.
the birth of a baby,
Uh-huh.
born to a teenage,
Huh?
born to a teenager
Uh-huh.
who wasn't married at the
She
time.
was no, she was not.
Okay, so we
No, she
can't.
was not.
Who was not married and gave birth as an unhoused couple
Mhm.
because they were unhoused. They
Mhm.
didn't have a place to stay.
They did not.
They did not
They
have
did
a place to stay. So it is very interesting to me that as we celebrate this birth throughout, yes, Christmas is the high point, but we celebrate throughout, that we don't really have a way as a routine. Now there are different churches who do different things
not.
to celebrate the birth of young ones who are part of our congregation.
Mm.
Now I contrast that to the death of individuals where there's announcement and whatever ministries, auxiliaries, or whomever press into service to provide meals, to give calls, to offer their assistance for the ceremony. Now, we do have christenings for babies, but when they get here, knowing what I know in terms of the isolation that individuals may feel, being overwhelmed, I'd like to see our churches be more involved at the pleasure of the families in terms of supporting them with some meals. Surely the family needs some meals, okay? I can remember when my first child was born, I said, I'm glad you all are coming because Dwayne can't cook nothing. And I'm just kind of on my own here, and I can't prepare those meals. Uh, could we be transportation of rides to the doctor? I remember talking about well-educated African American women. Over 20 years ago, I did an interview with a group of physicians, focus group rather. And I asked them, I said, tell me about what's the difference between your teenage mothers who come in and your well-educated mothers who come in. And what they said to me it was really startling. They said when the teenage mother comes in, she's accompanied by grandmama, auntie, some adult, but you have a real sense she has a community. When it's well-educated, unmarried individual, maybe she's married, she comes in by herself. And she comes alone and a teenager is surrounding. Now, that's an important point because it says to me what happens to that individual who may deliver by herself, doesn't have the supports, feels ostracized because maybe she's not partnered or doesn't have a spot, whatever the circumstances may be. So I wonder, how do we show up for those individuals? How do we show up? Where are we in the celebration of a new child? Where are we to support this new mother who may be subject to depression? We know that about a third of postpartum individuals experience depression. Now, what does depression look like? Well, depression looks like you can't hardly take care of yourself. So how are you taking care of a baby? You may push through, but a little support, encouragement would be wonderful to have. Now that's on the what we would call the expressive, the instrumental side of support. At the legislative side, we need to make sure that for those things that we're advocating, church advocate for housing. Many of you, I'm sure of you, the people who will be on this call may have housing programs. Well, is there something that's carved away for that pregnant woman who, because of interpersonal violence, had to flee? She needs a place to stay. She needs a place to stay. I mean, I've worked with the United Way, and I've been very pleased to see how they've worked with apartment uh, owners, and to carve out spaces that were specific for pregnant women to get them through the pregnancy and at least a year out, where they would have a place to stay. We don't need in this time manger births, if I may use that. Okay, to have a place to stay. Uh, if we are involved with transportation, to see what kind of transportation that could be carved out for those individuals during pregnancy. I worked in Clayton County here in Atlanta, partnered with Clayton County Board of Health, and they talked about how when the MARTA, for those who don't know Atlanta, the MARTA system stopped going out to Clayton, the nurses could see the decline in women making their prenatal visits.
Mm.
Okay? So part of the rationale or the advocacy to bring the MARTA back there was to say, this is affecting the healthcare. We've got to have this. So church is involved in that. Church's voices in terms of making certain that if we have Medicaid expanded for a year, or having their voices to see, and what is it expanded to? One of the things to me, Reverend Henderson, that is troubling to me, we all now have to recognize that mental health is an important aspect that has to be addressed.
Yes.
Okay, mental well-being.
Yes.
Now, people are ready to receive that help, but there are some problems here. And the problem has to do with access and lack of access because of cost.
Mm-hmm.
A number of therapists, and you can understand why, won't take Medicaid. Takes too long for them to be reimbursed. The reimbursable rate is low for whatever reasons, won't take it. So now we are saying for individuals to go see a therapist, clinical social worker, to psychologists, and psychiatry is under the medical realm, so you might get that care there, but they're not necessarily therapists. So how do we close that gap? I was listening to a young Black woman the other day who was a therapist, and she said, I got my degree to be a therapist, And I took out loans. Black women are some of the highest population in terms of loans for college. And I thought I could help people who look like myself in terms of addressing their mental health concerns, but I can't do it. I can't afford to do it without individuals paying. So I feel bad because I can't provide the services that I trained for to do because there really is a real gap there. I'm very concerned about that. And for the policy wonks, we need to address that because we we really can't give people equity in terms of mental health care. And equity, what I mean, is what you need and what you desire to have. So if you desire to have a Black woman therapist, you should not be shut out from that because of the way the structure is set up so that she can't afford to take you and you can't afford to pay her. There's something wrong with it. So those are, I think, as we are in the spaces, in the rooms, to do those things, to see what is needed, and they're little things. I work in my church. We provided little clothes for preemies. And they're tiny, tiny clothes, but to provide clothes or go rock those babies. Now that's personal, skin to skin. That's personal. That's a, and I think that probably is happening. But as we go higher up, as we do other things as churches, we have to be in the room to be a voice when the decisions about housing are being made, to be in the room to be a voice when the decisions about transportation are being made, to be in the room to be a voice when issues about workplace and pregnancy are discussed. Some individuals don't get to the doctor for fear they will be penalized. Taken off work. They don't go. And if there's something that goes amiss, it can really go amiss. It can really, really go amiss. So those are the kinds of things. First, acknowledging the birth of these precious individuals, acknowledging and looking to the mother, the parent. What do they need? Don't forget them. We're happy to have this little person, but don't forget them. What do they need? What do they need in terms of support for them in the workplace? Support for them in terms of having a place to stay? Support for them in terms of getting the medications that they can have at a cost that they can afford. Those kinds of things, and certainly being in the legislative space to understand that we have a role. Now, the housing issue is one that can go a lot of ways, and so we need to talk about what can be our role around the housing. So those are the things, Reverend Henderson, that I think about most, knowing, and of course, continuing to give the spiritual support for families when they're in this journey. We can't have individuals dying, and more than dying, being sick for their lives, for their entire lives. And I want to say we've put a lot of emphasis on maternal mortality, and the reality is that most births are okay; they come out okay. But every life is precious, and so we have really mounted the campaign to end this. But I say this so the individuals who are considering childbearing, that they won't be afraid. If it were as threatening as sometimes we write about it, we would cease to exist. And to promote different models of healthcare. As I told you, I come from a midwife. That was all they had. And babies are born all over the world. In some places that are most in hospitable, but they come. They come. They come.
Dr. Jackson, thank you so much for your lived expertise. Thank you so much for your research and for making it uh, palatable for those in faith communities seeking to do something. What I heard over and over again was that there is an intersectional component to this,
Mhm, mhm,
that there's more than one way to address this issue.
mhm,
Um,
mhm,
and I see that is a task that uh, for me as a leader of faith that I will take on, uh,
mhm,
and that I pray for churches and faith communities listening, that they will take on as well.
mhm,
So
mhm.
thank you so much for spending the time with us. Uh,
Yes, yes,
and
yes.
I, again, am eternally, eternally grateful for
Thank
the
you.
wisdom that you have imparted. Thank you.
Thank you so much for this opportunity to share.
Thank you. All right. I just am so grateful to be able to have spent that time with Dr. Jackson and for her to share with us her wisdom and her expertise in her research and sharing her research findings with us. But then also her reflection on how we might be able to better respond as a community of faith to this issue of maternal and infant mortality. As is our custom, go ahead and drop in the chat a word or phrase that you gleaned from this conversation. What was made clear to you? What had you not considered before this conversation? Go ahead and drop that reflection, that word in the chat right now. I have a few updates. One, as you all know, we have a weekly devotional podcast that you all can listen to throughout the course of this module. And as I shared before, we will be examining this notion of the spiritual determinants of maternal health, right? And how that might show up within our faith spaces. Dr. Jackson talked about how faith and spirituality served as a mediator to stress. And so I think that is something for us to explore within the faith community. And also be on the lookout. We are currently in the process of endorsing a new piece of legislation called the Care for Moms Act. This piece of legislation is being sponsored by Representative Robin Kelly's office, and we will be sending out an action alert. We want to make sure that we are connecting how we show up in the pew with how we show up in the public square. And this is one of those examples. We definitely need you all to make sure that you are advocating and that you are in conversation with your congressional leaders so that they will be in support of this bill. This bill supports the type of structures that we talk about in terms of what is needed to promote better maternal health outcomes. And we're hopeful that we can do what we need to do to ensure that it passes. So be on the lookout for an action alert about the Care for Moms Act and make sure that you get your community involved, not just you. In addition to you, the ministries and the congregations that you represent, get them involved in advocating and letting their congressional leaders know that this is something that is on our radar. The General Board of Church and Society has endorsed this piece of legislation, and we want to see to it that it is passed effectively. You all, I am so grateful for the time that we have spent together, and I look forward to the conversations that will come up out of what has been discussed this evening. Until next time, my prayer is always that you will go in grace and that you will go in peace. Take care.